Welcome. I am Terry Tropin, and today I'll be discussing CPT coding for obstetric services. First, let me start with information about myself. I have a master's in healthcare administration informatics from the University of Maryland Global Campus and have RHIA and CCSP certifications. I'm also an HEMA approved ICD-10 trainer. I taught health information technology at Montgomery College for over 20 years. I also have written books on coding, and here are my books. I have a book on evaluation and management coding made easy, ICD-10-CM coding guidelines made easy, ICD-10-PCS coding guidelines made easy, and also a little mini book on changes to 10-CM and 10-PCS coding books, changes 2024 made easy. This book and the PCS, the PCS book include the changes that will be effective April 1st, 2024. So they're updates April 2024, and those are included in these books. These books are available on Amazon, updated every year or as needed. So, if you would like a copy of the slides for this video, do a like for this video and send me an email with your email address, and I will send you a PDF of the slides. So here's what I'm going to talk about today. I'm going to talk about the global obstetric package, antepartum care only, delivery care only, postpartum care only, how to code for twins, and then what kind of obstetric services are always reported outside the global package, obstetric services that may or may not be part of the global package. Now, I'm not going to talk about abortions and miscarriages, obstetric ultrasounds, not in detail anyway, or ectopic pregnancies. This would make this video much too long. I may discuss these in a separate video, but I'm not going to talk about these in detail for this video. So first, let's look at the global obstetric package. Since obstetric services, as we know, last approximately 9 months, CPT has a single code that covers the whole time period, including approximately 6 weeks postpartum. So think of the services, this 9-month period, all contained in a box. So here's our box. And this is the global OB package. And this is reported with one code. In that box, within that code, are routine antepartum care, routine delivery care, and routine postpartum care. This is represented by the single code. So the specific code depends on the method of delivery, but all of these services are reported by a single code. So if one physician or one practice of the same specialty provide all of the routine antepartum, delivery, and postpartum care, you're going to report a single global OB code. See how simple that is? If only they were all that simple, huh? If the patient is seen by another physician outside the practice for any of this routine care, you cannot report the global OB service. So if delivery is reported by somebody else, another practice, you can't report the global OB package. If your practice reports the antepartum care and the postpartum care, but somebody else reports the delivery code, you can't report the global OB package. So the global package includes routine antepartum care. But what does that mean? Well, the CPT book defines this. Routine antepartum care includes initial and subsequent history, physical exams, documentation of weight, blood pressure, and fetal heart tones, routine chemical urinalysis, monthly visits up to 28 weeks gestation, biweekly visits up to 36 weeks gestation, and weekly visits up to delivery. So what does routine delivery care include? Well, it includes admission to the hospital, admission history and physical exam, management of uncomplicated labor. There's that uncomplicated routine care. Remember, routine is what you give to, what's provided to every patient or almost every patient. Delivery, either vaginal or cesarean, delivery of the placenta. It may or may not include episiotomy. It may or may not include forceps delivery. And finally, there's routine postpartum care. Hospital and office visits following delivery, normal follow-up care for 6 weeks after the delivery, such as hospital visits, office visits. Now, there are 4 possible global package codes. The specific code that you'll report depends on the method of delivery. So there are 4 possibilities. So if it's a vaginal delivery, here are the codes you're going to use. If the delivery is vaginal, you're going to use either 59400 or 59610. 59400, routine obstetric care with vaginal delivery with or without episiotomy and or forceps and postpartum care. 59610, routine obstetric care with vaginal delivery with or without episiotomy and or forceps and postpartum care after previous cesarean delivery. Why does their previous delivery matter? Well, the previous method of delivery matters because if she had a cesarean before, there'll be scarring from previous cesarean, which makes this delivery riskier. Different code, higher reimbursement because it's riskier. So 59610 is in there. So it's important to note that she had a previous cesarean, even though this one is vaginal. If the global package is reported, but this delivery was by cesarean, you're going to use one of these codes, 59510 or 59618. 59510, routine obstetric care, including antepartum care, cesarean delivery, and postpartum care. So that's whole routine care. 59618, routine obstetric care, including antepartum care, delivery care, and postpartum care following attempted vaginal delivery after previous cesarean delivery. Note that 59618 reads following attempted vaginal delivery. Now, you may not find that documented. Attempted vaginal delivery, you can still use this code even if that's not in the record. All you need to know is she had a cesarean before, she's having a cesarean this time. So don't worry about documentation of an attempted vaginal delivery. So let's do a practice. I'm going to read this, and if you'd like to try to do this on your own, stop the video and then restart it after you've thought this through yourself. So Babies R Us, an obstetric practice, includes doctors A, B, and C, all general OB-GYNs. For this patient who is pregnant for the first time, that's important, Dr. A provides 5 antepartum visits, Dr. B provided 7 antepartum visits and performed vaginal delivery, and Dr. C provided the postpartum care. How is this coded? So pause it if you'd like to think about this for a minute. Okay, so we're going to do 59400. Even though 3 different physicians provided care, they're all in the same practice, all general OB-GYNs. So you're going to report the global code, and the physicians in the practice will figure out how to divvy up the amount that's paid. All the physicians are in the same practice, and this is her first pregnancy, so the previous pregnancy deal doesn't apply here. So the easiest way to code for pregnant patients is if the same provider or group sees her throughout the pregnancy. That's what you hope for. Unfortunately, this is often not the case. So let's look at how to code for different providers in different groups. What if the physician provides only the routine antepartum care? Well, there are codes for that. 59425, antepartum care, 4 to 6 visits. 59426, antepartum care, 7 or more visits. Now, CPT guidelines say these codes are reported once for the range of visits. That is, if she's seen for nine times, report 59426 one time. Now, some payers have different rules, so you may want to check. Now, what if she's seen for less than 4 visits? So in this case, report an E&M service code for each visit. So this is kind of confusing rules, but CPT says report one time. Other providers may have different rules. So here's a common scenario. Suppose you are pregnant. You see Dr. A for 5 visits, then you move to a different city and see Dr. B for 8 visits. How would these physicians report the services they provided? Dr. A reports 59425, antepartum care only, 4 to 6 visits, one time. Then Dr. B reports 59426, antepartum care only, 7 or more visits. So each one can report this was a specific code for the services they provided. What if the physician provided only the routine delivery? You have 59409, vaginal delivery only, 59514, cesarean delivery only, or 59612, vaginal delivery only after previous cesarean, and 59612, cesarean delivery only following attempted vaginal delivery after previous cesarean. And again, there's that following attempted vaginal delivery, which you don't really need to deal with. So there are 4 possible codes if only delivery is done. So what if the physician provided only the routine postpartum care? You have 59430, postpartum care only, the separate procedure. So suppose you are pregnant. You see Dr. E for all your antepartum care and the delivery. Then you move to another town. You see Dr. F in your new town for your postpartum visit. Dr. F reports 59430. Here's another possibility. Suppose you're pregnant. You see Dr. C for 12 antepartum visits. You go into labor but find Dr. C is out of town. You go to the hospital and meet Dr. D, who performs a vaginal delivery. Dr. D is from a different practice than Dr. C. You see Dr. C for the postpartum visit. So Dr. C reports the antepartum visit and the postpartum visit. He didn't do the delivery. So Dr. C does 59426, antepartum care only, 7 or more, and a code 59430-59. There's a 59 modifier for the postpartum care because 59430 is a separate procedure code. So he has to do the 59 modifier, distinct procedure. Then Dr. D reports the vaginal delivery. Okay. So they have to separate. They can only report what they actually performed because they're in different practices. So what if we're trying to cover all possibilities here, right? So what if the physician provides routine delivery and routine postpartum care? So there's 4 possible codes for this too. 59410, vaginal delivery with postpartum care. 59515, cesarean delivery with postpartum care. 59612, vaginal delivery after previous cesarean with postpartum care. And 59622, cesarean delivery after previous cesarean with postpartum care. So whatever combination of care out that's not global, there's a way to report only the services that your physician actually provided. So what about twins? Many years ago, I worked for the American College of OBGYNs, ACOG, answering coding questions. They would, sorry how old this is, they would fax them in, or they would call for or email questions in. And the most common question I got is, how do you code for twins? Most often. Payers vary on this one, which is unfortunate. But ACOG's recommendation was modifiers 59. So do one global package code and a delivery only code with a modifier 59. Distinct procedure. Because the what you're doing, whoop, I won't let me go back. Why won't it let me go back? So what you're doing, I'm sorry. What you're doing is you're doing a modifier 59, you're doing a global package code, and then you're doing a delivery only code with the modifier 59. Because you're not doing two global package codes. Right? Because you're not doing two full distinct global packages for this patient. You're doing a global package code and then a delivery only code, but you have to do a 59 modifier on that, because otherwise they'll say, well, delivery is, part of the global package. Now, some payers will want you to do a 22 modifier. Some will want you just the global package with a 22 modifier on it. Some will want you to do a global package and then a delivery only with a 51 modifier. So check with your payer for that. So here's a practice. Now, the other thing to note is that if you're doing a vaginal delivery followed by a cesarean delivery, use the cesarean global code plus a vaginal delivery. Now, of course, you're going to do the vaginal delivery for the first one and then a cesarean delivery for the second one, right? But you're going to do the cesarean global, okay? Why is that? Well, it's high reimbursement for one thing. And also you have the additional risk for the cesarean, even though the vaginal was first. So it's not a matter of which one was first, it's a matter of which one was riskier, okay? So, and also if it was triplets or quadruplets or, gosh knows how many babies it could be, report a global code plus a separate delivery code for each additional baby with a modifier 59, okay? So here's a practice. The patient is pregnant with twins. This is her first pregnancy, so that does away with after previous codes. She received all her antepartum care, the delivery, and the postpartum care from Dr. Jones. Twin A was delivered vaginally. Twin 2 was delivered by cesarean. How would Dr. Jones report this? Pause the video if you want to think about this. So we're going to report the global cesarean code because that's the riskier one and the higher reimbursement. But it makes sense, not just doing this for reimbursement. We're doing this because this is the riskier code that represents the higher risk of the cesarean. So we're going to do 59510 for the cesarean and then a vaginal delivery 59509-59. Now again, check with your payer because they're all over the place on this one. Now, unfortunately, it's not always clear whether a patient who walks through the door pregnant will stick around for all the global package care from a single payer, single practice. Patients move, they lose their insurance, they change insurance and find that this obstetrician is not under their new plan, or they might just decide, you know what, I don't like this obstetrician, I'm going to change, okay? Or another obstetrician is closer to where they live, okay? So how do you deal with this? The physician should document each visit or service when it's provided, but they don't yet report the global OB code to the insurer, okay? This is for the routine services. They may be able to do the global, but they can't be sure. For the non-routine services, you can report that at the time of service, and we'll talk about what non-routine services in a minute. You can report that when they occur because those are not part of the global. After the delivery, when a postpartum visit has been scheduled, then you can submit the global package code to the payer. Now, some services are not part of the global package. Remember that I emphasized routine services provided to all or most pregnant patients. These are all, we talked about these here: routine antepartum care, routine delivery, routine postpartum care. So these are all in the box. Here are the ones outside the box, and these are the non-routine services. So what's a non-routine services? That can be reported at the time of service. They don't have to wait until the global services have been completed. So these include the patient comes in for a pregnancy test or confirmation of the pregnancy. You can list the E&M service. Now, the patient may get prescribed vitamins at this time. You make the next appointment for the first global appointment, but this is not part of the global package. Fetal invasive procedures, radiology procedures like ultrasounds, laboratory tests, except for those that are included in the package, like the routine urinalysis. Treatment of complications of the pregnancy, complications of the delivery, postpartum complications, and unrelated conditions present during the pregnancy. Those are not part of the global package, and they can be reported when they happen. So let's look at some of these. The introduction to this section says this: for surgical complications of pregnancy, e.g. appendectomy, hernia, ovarian cyst, breast cyst, see services in the surgery section. This means they're not part of the global package. Medical complications of pregnancy and medical problems complicating labor and delivery management may require additional resources and may be reported separately. Again, not part of the global packages. The tricky part is that many services are always outside the global package, but a few are sometimes outside the global package, but sometimes included in the global package. Timing. We'll talk first about those that are always outside the global package, and then some that are sometimes outside the global package. First, let's talk about those that are always outside the global package. Services that are not part of the global package, if they're provided by the same physician or group, report both the global OB package and codes for the non-routine services. For example, a group may include general OB-GYNs and maternal fetal specialists. So if there's a problem, the general OB-GYN in a group may refer the patient to a maternal fetal specialist within that group. If there's a problem with the baby, there's a problem with the mother, there's a complication, and they'll send them to a maternal fetal specialist. The general OB-GYN can report the global package, but the maternal fetal specialist can report the problem with an appropriate diagnosis. On the other hand, one group may be reporting the OB package and send the patient to another group for a problem. So then Group A reports the global OB package, Group B reports the non-routine services. So in this case, one is reporting the global package, the other one is reporting the non-routine services. So let's start with services not part of the global OB packages. Be sure and list a diagnosis code for the other conditions. So what is the problem? Why is this a non-routine service? Why is this being provided? So here's some examples, just examples. It may or may not be what the problem is in this specific case. Malignant neoplasm complicating pregnancy, childbirth, and puerperium, 09A.1, plus a code for the specific malignancy. That's obviously a problem thank goodness, not routine, not seen for every patient. Pregnancy complicated by diseases of the digestive system, 099.61, and then also acute appendicitis, K37.210. Traumatic fracture of left foot, S92.902, pregnancy state incidental, Z33.1. Obviously, the fracture of the left foot has nothing to do with the pregnancy, but you do the fracture and then the incidental, and like kind of, oh, by the way, she's also pregnant. CPT code, in this case, maybe a surgery, maybe testing, maybe an E&M code as appropriate. Now, I also state that I did a video a while back on CPT coding for pregnancy. It included diagnosis coding for pregnancy and PCS coding for pregnancy, and I will do a link to that at the end of this video. So let's look at some procedures that are always outside the practice. Let's look at amniocentesis. This is insertion of a needle into the pregnant uterus to withdraw fluid. If it's diagnostic, to examine the fluid to see what a problem is, it's 59000. To collect fluid for pathological examination. Code also an ultrasound guidance code if ultrasound guidance was indeed. You want to be sure you're getting fluid, not poking the fetus, right? If it's therapeutic, if there's too much fluid and you want to remove some of it, it's 59001 to drain off excess fluid. And this includes ultrasound guidance. So there's got to be careful with this. In this case, you're coding also ultrasound guidance. In this case, the code includes guidance. Another code that's not part of the global package is amnioinfusion. This is kind of the opposite. Amniocentesis removes fluid. Amnioinfusion adds fluid. This is also not part of the global package. Abdominal approach includes ultrasound guidance, 59070 rather. Cordocentesis, blood sample of the umbilical cord is removed for testing, 59012. This is intrauterine and does not include ultrasound guidance. So if guidance is used, list 76941. Chorionic villus sampling, tissue from the placenta is removed for testing, 59015. If guidance is used, it refers you to 76945. So fetal contraction stress test. So this is measures response of fetal heart rate to stress, artificially induced uterine contractions. See how the heart responds to that. Performed at 34 weeks, 59020. Monitoring heart rate to see without stress to fetus, without the stimulation, 59025. Fetal scalp blood sampling, sample of blood when mother is in labor to see if the fetus is receiving enough oxygen. Again, this is not done to every patient, so this is reported separately. If test is repeated, you're going to use a modifier, 76 or 77, depending on the circumstances. Fetal umbilical cord occlusion, when there's multiple fetuses, if there's a defect in one of the fetuses, they'll block off the umbilical cord of the fetus with the problem, and so the other one can survive, and this includes ultrasound guidance. Fetal fluid drainage to drain off excess fluid. In urinary bladder, the chest, the abdomen, includes ultrasound guidance. This is one-time drainage. If it's drainage over time, use a shunt, and this is 59076. Includes ultrasound guidance. This is over time. cephalic version. This picture is kind of misleading because it looks like the physician has their hands on the fetus, but actually it's outside the uterus, and they're kind of moving the baby from outside, not on the fetus. It's kind of, I think it's misleading, and you probably know they don't have the hands on the actual baby. But anyway, 59412, turning the fetus in a head down position for vaginal delivery when the baby is breech. You want it to go head first instead of butt first, or shoulder first, or whatever, so they don't have to do a cesarean. It's much better for the baby and for the mother, for sure. With or without drugs. Postpartum curettage removes remaining pieces of the placenta, clotted blood, or hemorrhage. 59160. This also is not done for every patient, therefore it can be reported separately. This is not routine. You need to have a diagnosis to show that. So if it's curettage is performed but it's not related to a pregnancy, you have 58120. Hysterorrhaphy, sometimes the uterus will rupture during delivery. 59350, and that's repair. Luckily, that is not always part of a pregnancy. Cerclage. Now, placing the cerclage is separately reported. Removal of the cerclage may or may not be reported. It's reported separately only if anesthesia is used. Usually, it's a snip, right? Usually, it's reported separately only if anesthesia other than local is used. Usually, the cerclage is removed at time of delivery, so it's no anesthesia is used, and it's just snip. Now, ultrasounds can also be reported separately. You have fetal and maternal evaluation, detailed fetal anatomical exam, fetal nuchal translucency, limited follow-up transvaginal biophysical profile, Doppler velocimetry, and echocardiography for the fetus. So these are reported separately. It's good to have a reason to do them, a diagnosis showing why they're being done, but they can be reported separately. Now let's look at these. These are trickier. These are procedures that may or may not be part of the global package. It's all timing. First, look at cerclage. Placement of the cerclage with the diagnosis of cervical incompetence is outside the global package. Removal of the cerclage may or may not be outside the package. It is only outside the package if anesthesia other than local anesthesia was used. Usually it's removed as part of the delivery and is therefore part of the delivery and part of the global package. So 59050. Oh, fetal mom. Oh, I'm sorry, my script is messed up. Fetal monitoring during labor, not part of the global package when performed. Okay, let's stop this. No. Okay, notes to make in your book. Remember, these changes are not in your book. So you need to make notes throughout your book to indicate the changes. Do something to make sure that you know these changes. This will give you the opportunity to report new, more specific codes, but also the danger is that you may report old codes that are no longer valid, and that means they will not be paid. So you can see how important this is. If you look in the description of this video, you'll find the link to the changes on the CMS website if you want more information. Okay, notes to make in your book. Remember, these changes are not in your book. So you need to make notes throughout your book to indicate the changes. Do something to make sure that you know these changes. This will give you the opportunity to report new, more specific codes, but also the danger is that you may report old codes that are no longer valid, and that means they will not be paid. So you can see how important this is. If you look in the description of this video, you'll find the link to the changes on the CMS website if you want more information. So again, here are the books I've written on coding, evaluation and management, CM, PCS, and a book on the changes. All of these are up to date as of April 1. So if you want to contact me, if you'd like a copy of these slides, a PDF of these slides, send me an email right here. If you want to comment, send me an email right here. So here are my books, and they are updated every year, or as you can see, as needed, since they're making changes in April. Thank you very much for listening. I hope this was worthwhile.